friends. Now we are going into the super specialty level topics. So all these topics have been very less asked in the past exams. Now from the NEET 2020 we found around 20 questions from this section alone. So therefore I had to focus more on this section and I'm focusing more questions in this section. And the first session we are going to discuss is on urology. In urology we are going to discuss about the diseases of kidney, ureter, bladder and urethra. Okay. So we are going to discuss about kidney, ureter, bladder and urethra. Certain basic points which I want to know before discussion are. So this is kidney and this is renal pelvis. This is known as renal pelvis. Okay. And this is ureter and this is ureter. And here this is bladder. So now we are going to discuss only this part of the topic. So in kidney, certain surgical anatomy points I want you to know. There is one line on the greater curvature. On the greater curvature of the kidney, there is one line. That is a avascular plane. What is the name of that line? The name of that line is Brodal's line. Avascular line on the greater curvature of kidney is known as Brodal's line. Okay, Brodal's line. So please don't forget this Brodal's line. And now this point is very important point. This is known as pelvic-ureteric junction. So PUJ. So this point is very important point known as pelvic-ureteric junction. And this point is another important point here. The place where the ureter is entering the bladder will be here. For example, this is the place where the ureter is entering the bladder. This is known as VUJ, vesico-ureteric junction. So pelvic-ureteric junction and vesico-ureteric junction are two important junctions you must know. Pelvic-ureteric junction and vesico-ureteric junction are two important junctions you must not forget. So the other narrow points in the ureter where the ureteric stone can get obstructed are the following. So the first narrowest point is already told, pelvic-ureteric junction. Okay. Pelvic-ureteric junction is first narrowest point. The second narrowest point is crossing of common iliac artery. This is the crossing of common iliac artery which divides it further into external iliac and internal iliac. So crossing of common iliac artery is the second narrowest point. Okay, crossing of common iliac artery is the second narrowest point. And the third narrowest point is at the crossing of vas deferens in males, vas deferens in males and round ligament in females. So crossing of vas deferens is the third narrowest part. So the fourth narrowest part is here. That is at the point of entry into bladder. Entry to bladder. So entry to bladder is the fourth narrowest point. So the fifth one is vesico-ureteric junction. So the most common site of stone obstruction in the ureter is VUJ. Most common site for ureteric stone obstruction is VUJ. So please don't forget these points. So this is kidney, renal pelvis. This is renal pelvis, and this is the ureter. Ureter has 5 constrictions. Number 1, pelvic-ureteric junction. Common iliac artery. Number 2, vas deferens. Number 3, entry to bladder. Number 4, and vesico-ureteric junction is number 5. That is the last point. So please don't forget these 5 narrow points. 5 narrow points in ureter you should not forget. Okay. So this is basic anatomy which is needed for a surgeon. The length of ureter is around how many centimeters? It is around 20 centimeters. Now we are going to discuss the basic investigations of kidney. Kidney investigations. Kidney investigations. Many times when we are doing CT scan for some pathology when we are doing CT scan, we find a cyst in the kidney like this. So we find most of the time when we are doing some other pathology investigation, we find a cyst in the kidney like this. We find a cyst in the kidney like this. And this cyst in the kidney is investigation of choice is CECT abdomen. Is investigation of choice in cyst. And the name of the classification of cyst is known as Bosniak classification. Bosniak classification is a classification of cyst in the kidney. So please don't forget, Bosniak classification is a classification of cyst in the kidney. Number 1, it's a simple cyst like this with no septation, nothing. It is a simple clear cyst with no septum inside. It is one is a simple cyst. So 2 is a cyst which is having minimal hairline septations. So it is also known as benign cyst. Benign cyst, what does it contain? It contains hairline septations, very small hairline septations. Okay, so there is no calcification, no soft tissue component, nothing. But there is small hairline septations seen. Okay, hairline septations are seen. So coming to 2F, there is one 2F, which is also known as in complex cyst. It's also known as complex cyst. So it is having more hairline septations. But interesting point is they don't have no soft tissue component. They don't contain soft tissue component, but they have hairline septations are present. Hairline septations are present, but they don't have enhancement. The septations will not enhance on contrast. So that is 1 is simple cyst, 2 is benign cyst with very few hairline septations, 2F is complex cyst with more hairline septations, but they do not enhance. They do not enhance on contrast. So these 1, 2, 2F, they have very 0% risk of malignancy, and complex cyst may have less than 5% risk of malignancy, and no further evaluation needed for these cases. So no further evaluation, we can just send them home. No further evaluation needed, or we ask them to come for follow-up after 1 or 2 years. So otherwise 1, 2, 2F cyst, nothing to worry. The problem comes with 3 and 4. So very important, 3 is an indeterminate mass. Indeterminate mass. So in the indeterminate mass, cyst wall, what is that? Cyst wall plus septations show enhancement. Septations show enhancement is seen in these 2. So septations as well as cyst wall show enhancement is 3. And 4 is a condition which contains soft tissue components. Hence it is known as malignant cystic mass. Malignant cystic mass, there is soft tissue component present. Soft tissue component is present. Therefore 4 has 100% risk of malignancy. 3 has 50% risk of malignancy. So 3 is having 50% risk of malignancy. 4 is having 100% risk of malignancy. Therefore biopsy must be done for biopsy advised for 3 and 4 cases. We must advise biopsy. 3 especially biopsy should be done, and 4 in fact is mostly a malignant mass. Therefore you can even resect the mass. Okay. So this point I want you to remember for your exams. So what are the points you must remember for your exams? Is in case of kidney cyst, CT scan classification is known as Bosniak classification. Please don't forget Bosniak classification. It is there in Bailey and Lowe. 1 is a simple cyst, 2 is a hairline containing benign cyst, 2F is a complex cyst, 3 is indeterminate mass. 3 is indeterminate mass. It is having 50% malignancy. 4 is malignant cyst. It is having soft tissue components. 4 must be resected. 3 must be biopsied. 3 must be biopsied. So what are the important investigations in kidney are? I want you to remember DMSA scan and DTPA scan. Dimercaptosuccinic acid scan. Dimercaptosuccinic acid scan is DMA. Diethylene triamine pentaacetate scan. Pentaacetate scan is DTPA. Okay. So now another one scan has come known as MAC3 scan. MAC3 is mercaptoacetyl triglycine scan. So usually the expansion is not being asked in exam, but they have asked what is the use of each scan. Special scans in kidney. Okay, special scans in kidney. Dimercaptosuccinic acid scan. DMSA scan. I will make one method, remember it easily. DMSA contains M. So it is used to study the morphology of kidney. So any problem in the morphology of kidney can be studied. Renal morphology investigation of choice is DMSA scan. And DTPA contains P. So therefore it is used to study the perfusion pathologies in the kidney. And otherwise, DMSA is for anatomical morphology, anatomical study. DTPA is for physiological study of kidney, So DTPA is for perfusion of the kidney. DMSA is to study the morphology of kidney. So therefore, if there is any obstruction, something, for example, there is a pelviureteric junction obstruction, DTPA scan will show that pelviureteric junction obstruction can be picked up by DTPA. The contrast perfusing inside and coming out is shown by DTPA scan. So nowadays, DTPA scan is more replaced by MAC3 scan. DTPA scan is more replaced by MAC3 scan. And investigation of choice, this question is an expected question. For pelviureteric junction obstruction, answer is what? Is MAC3 scan. MAC3, mercaptoacetyl triglycine scan. Okay, investigation of choice for pelviureteric junction obstruction is MAC3 scan. Please don't forget MAC3 scan. Okay, so these are the basic introduction of the renal investigations. Now I'm going to discuss renal stones. One of the important topics in this chapter is renal stones. It's a very basic undergraduate level topic, so UG is also it's very important for MBA students. You must know everything about renal stones, and you must not forget any point in this. What I'm going to tell. So what I'm going to tell is 100% coverage of renal stone, ureteric stone, bladder stone. I'm going to cover everything. So now renal stones we are going to discuss. Now before going to the discussion of renal stones, let us discuss the clinical feature the patient comes to you in a patient with stones. So the stones may be asymptomatic most of the time. Many of you will be having a stone without any symptoms. So it is asymptomatic most of the time. So the symptoms may happen when the stone is causing some obstruction in the calyces of kidney, or it is having some obstruction in the, what is this? PUJ, pelviureteric junction obstruction, or the stone can get obstructed on the level of mid-ureter. So renal stone, PUJ stone, mid-ureter stone, lower ureter or VUJ stone, lower ureter or VUJ stone. This is what we say as stones at the level of pelvic brim. So pelvic brim, pelvic means this is a bone. At the level of pelvic brim, the stones are seen in lower ureter or at the level of VUJ. Or the stone can be there in the bladder. The stone can be there in the bladder. So what are the symptoms which are going to happen with these all guys? I'm going to tell you now. Okay? What are the symptoms which are going to happen now? A stone in the kidney itself will have only back pain. They'll have back pain. They'll have back pain. So stones in the pelviureteric junction or in the upper ureter, pelviureteric junction or upper ureter will have pain radiating from loin to where? Radiating pain from loin to testicles. Very interesting point. So loin to testicles means there is some nerve which is carrying that pain from loin to testis. So can you tell me what is that nerve? What is that nerve that carries the pain from loin to testis? Can you tell me? The nerve is genital branch of genitofemoral nerve. Please don't forget this is an expected MCQ. Already asked also in exams. So the pain radiating from loin to testicles is by genital branch of genitofemoral nerve. Mid-ureteric pain mimics like appendicitis. Mid-ureteric pain mimics like appendicitis on the right side and as diverticulitis on the left side. VUJ stone causes pain radiating from loin to where? Loin to groin. So don't get confused in this. So loin to groin is VUJ stone. Loin to testicle is PUJ stone. Loin to groin is VUJ stone. So loin to groin, also known as medial side of thigh. What is the nerve involved in? What is the nerve involved in loin to groin? Which nerve carries the pain from loin to medial side of thigh? Ilio-inguinal nerve is better answer than ilio-hypogastric nerve. So both can carry the pain, but which is better means ilio-inguinal nerve is better answer here. So loin to testicles is by genital branch of genitofemoral nerve. Loin to groin is by ilio-inguinal nerve is better than ilio-hypogastric nerve. So another one stone which is infiltrating into the ureteric wall, intramural stone. Intramural stone, in the intramural ureteric stone. The ureter is impacted somewhere inside the ureteric wall, will cause a pain which is known as strangury. That is known as strangury. So what is strangury? At the end of micturition, the patient will have intolerable pain. He will pull his penis out. Because of intolerable pain, he will pull the penis outwards. So to have reduction of pain. So that is known as strangury. Strangury is a classical MCQ seen in intramural ureteric stone. Okay. So please don't forget a stone in the pelvic brim. A stone in the pelvic brim or in the lower ureter will have pain radiating from loin to groin, also known as thigh, medial side of thigh. Please don't forget, also known as medial side of thigh. So please don't forget, this is a very important table, the picture I have made here. So back pain and kidney alone. Pelviureteric junction will have pain radiating from loin to testicles. Mid-ureteric stone will mimic like appendicitis. VUJ stone will have pain radiating from loin to groin or thigh. The reason for this, the nerves are genital branch of genitofemoral nerve for PUJ stone, ilio-inguinal nerve or ilio-hypogastric nerve for VUJ stone. Okay, don't forget this. Another other interesting clinical features are Dietl's crisis. What is this? Dietl's crisis in kidney stones. Dietl's crisis is a condition in which the stone obstructs the ureter like this. The stone obstructs the ureter like this, and that kidney goes for hydronephrosis. This patient now goes and takes a bottle of beer or alcohol. Okay, beer or alcohol is taking. Now, after taking beer, so alcohol is a diuretic, so the stone is pushed out. The stone is pushed out. So initially the patient will present to you with the pain and loin mass. The patient presents to you with the pain plus loin mass. The patient presents to you with the pain and loin mass. Severe pain and loin mass will be there. He takes a bottle of alcohol. The stone passed out and the patient passes enormous urine. Enormous urine is nothing but that obstructed urine comes out and obstruction gets relieved. Obstruction gets relieved, mass disappears. So this is known as Dietl's crisis. So please don't forget, this is also a clinical feature of kidney stones. So please don't forget the various clinical features in kidney stones. I'm telling you, Dietl's crisis. This is also a Dietl's crisis. What are the other clinical features? Other clinical features. So are hematuria. Hematuria is a classical finding seen in renal stone. Increased frequency, strangury. So all these are various features along with the pain I have already discussed, along with the pain. So the textbook used to describe the most worst pain a male can experience in life is a ureteric stone. Please remember the wording. The most worst pain a male person can experience in life is ureteric stone causing obstruction. A female, the most worst pain is pregnancy pain. Second is ureteric pain. But in male, the only most excruciating pain is ureteric stone pain. So when a patient with such a severe pain comes to you, your first treatment will be what? Though he is a known case of ureteric stone, the first treatment of that patient is injection Oviron or diclofenac. Diclofenac is the injection that should be given immediately to those guys. So please don't forget, injection treatment is diclofenac should be given. So after that we discuss everything. So that's why I'm immediately telling the treatment. A patient comes to you with a ureteric pain, that is the most worst pain in his life. Immediately put a diclofenac and then discuss anything. That is why I'm discussing before discussion putting injection diclofenac. This is more practical point. And coming to the types of stones. Types of stones. So what are the types of stones we have? Please remember the types of stones. So I'm going to discuss all the types of stones. All are important for your exams. So I'm going to discuss the 5 category of stones now like a table. The first, calcium oxalate stones. Calcium oxalate stones. It can be calcium oxalate monohydrate or it can be calcium oxalate dihydrate. 2 types are there. Calcium oxalate monohydrate or calcium oxalate dihydrate. Then calcium, magnesium, ammonium, phosphate stone. What is the other name for this? It is also known as triple phosphate stone, also known as struvite stone. Please don't forget this. Calcium, magnesium, ammonium phosphate or triple phosphate or struvite stone. Also known as struvite stone. Cysteine stone, uric acid stone, and other rare stones. Rare stones are indinavir stones, xanthine stones, are all other rare stones seen. So now let us discuss one by one. Calcium oxalate stones will be looking like this. Will have multiple prickles like this. Looks like what? It looks like mulberry. Therefore, it is also known as mulberry stone. It is also known as mulberry stone. Calcium oxalate stone is also known as mulberry stone, and this is the most common type of stone overall. Please don't forget, every word I'm telling is MCQ. Calcium oxalate stone is the most common type of stone overall. It is having multiple prickles on the surface, so it is also known as mulberry stone. And this is the stone most commonly causes hematuria. Most common to cause hematuria, because it is having mulberry on the surface. Mulberry surface, so it will cause hematuria. So basic points first I will tell you, afterwards I will discuss in-depth points. Coming to the triple phosphate stones, it is also known as struvite stones, also known as jack stones, also known as staghorn calculi. This is the stone which takes the shape of the calyces and looks like a staghorn like this. It is a staghorn stone or takes the shape of calyces. So this is the stone most common in infection. What infection? So urea splitting organisms like Proteus infection. So the most common organism in infection and the most common infection is Proteus. And triple phosphate is the stone most common in alkaline urine. All other stones are more in acid urine, but this is the stone seen in alkaline urine. So triple phosphate stone is also known as struvite stone, jack stone, staghorn stone, and it is most common in infections and it is most common in alkaline urine. Interesting point is it has a smooth surface. It has a very smooth surface. It is not mulberry like, it is smooth. It looks like a smooth surface. Cysteine stones are seen in cystinuria. This is cystinuria. It is a hard stone. It is made up of double sulfur bond is present inside. There is double sulfur bond present inside. So the cysteine stones does not contain calcium. No calcium is seen in cysteine stones. But in spite of that, cysteine stones are seen on X-ray because of bond. The double bonds. Bonds make it radio opaque. So interesting MCQ point. Otherwise, it does not contain any calcium component. Because of the bond, it is radio opaque. Because of the bond, it is radio opaque. Okay. Coming to uric acid stones, these are the only radiolucent stone among the 4. Radiolucent stone. It is smooth yellow color stones. Yellow color stones, smooth, and they are radiolucent stones. So uric acid stones are seen in conditions which are having hyperuricemia like in gout. Hyperuricemia. And patients who are having excessive uric acid will have this uric acid stones, like patients with gout and patients with cancers. The tumor cells are getting lysis and uric acid released, so they all will get uric acid stones more commonly. Okay. And indinavir stone is the stone seen in HIV patients taking indinavir capsules. And xanthine stone seen in xanthine oxidase deficiency. Xanthine oxidase deficiency patients will develop xanthine stones. The interesting point is xanthine and indinavir both are radiolucent stones. Both are radiolucent stones. So xanthine stones and indinavir stones both are radiolucent stones. Please don't forget this point. So xanthine stones and indinavir stones are radiolucent stones. So these are the basic points of all the stones. I want you to remember all these points. So calcium oxalate and calcium oxalate monohydrate, dihydrate are the 2 types of stones. They look like mulberry and they are the most common stones. And they are the most common to cause hematuria. Triple phosphate stone is struvite stone, staghorn stone, or jack stone. They are the most common stone in infection, especially Proteus. They are most common in alkaline urine. All other stones are seen in acid urine. The stones seen in alkaline urine is triple phosphate stone. Uric acid stones are also seen in acid urine. Calcium oxalate stones also seen in acid urine. Okay, please don't forget these points. Now let me tell you the urinary crystals. Urinary crystals. You have to examine the crystals in the urine to find out what type of stone the patient is having. Very few patients you can find out from the crystal itself. So for example, I told you the most common stone is calcium oxalate stone. What will be the crystal shape in that? How does it look like? This is the stone seen in calcium oxalate. What is this appearance? It looks like a bipyramidal stone. Bipyramidal stone. Calcium oxalate stones are looking like bipyramidal. Calcium oxalate dihydrate. Sorry, calcium oxalate monohydrate. Calcium oxalate monohydrate will have this appearance. What is this appearance? The crystals will be having this appearance known as dumbbell-shaped crystals. Dumbbell-shaped crystals are seen in calcium oxalate monohydrate stones. Okay, calcium oxalate monohydrate stones. The next stone is triple phosphate stone. I will tell you easy method to remember them later. Just understand the crystal shapes. Triple phosphate stone is having this appearance. What is this appearance? Where have you seen this appearance? In movies and all you would have seen, no. A Christian patient dying, Christian person dying, they keep a coffin lid. That coffin lid appearance. This is known as coffin lid appearance. Yes, triple phosphate stone looking like a coffin lid. And coming to cysteine stone. Cysteine stone has hexagonal shape. This is hexagonal crystals. So the crystals will be hexagonal crystals. Okay, hexagonal crystals. This is benzene ring. Benzene ring is seen in cysteine stones. Okay, cysteine stones. And there are some rare stones like brushite stones, which is having needle-like appearance like this, like a needle. Needle-like appearance is seen in brushite stones. Needle-like appearance. So needle-like appearance in brushite stones, benzene ring in cysteine stones, and uric acid stones. I told you uric acid is seen in multifaceted appearance. multifaceted appearance, multifaceted appearance, multifaceted appearance. Okay, so now how to remember all this thing? Very simple. So which is the commonest stone? Calcium oxalate stone. Therefore, when you see a common person, very common person, we will pray him. As you see a pyramid, we pray. So like that, remember 5 pyramidal crystals. The hardest stone to break by ESWL is this. Hardest stone to break by ESWL is calcium oxalate monohydrate. So the hardest person is who is doing regularly a dumbbell exercise. So dumbbell stones are seen in calcium oxalate monohydrate. Monohydrate. So what are the order of breaking of ESWL stones is? ESWL, the hardest stone to break is given by the mnemonic MBC. Calcium oxalate monohydrate, brushite, then only comes your cystine. So remember, then only comes your cystine stones. So if you get calcium oxalate monohydrate, that is first. Second, brushite. Third, cystine. So therefore, I'm telling calcium oxalate monohydrate, the hardest stone to break. Therefore, dumbbells they are using. I told you the stone seen in infection is triple phosphate stone. So if there is an infection, patient will die, and we keep a coffin lid on him. Cystine is having a ring. Cystine is having a ring appearance. Brush is having multiple needles, needle like brush. So needle crystals. Uric acid is caused by multiple problems like gout, cancer, eating so much of non-vegetarian. All these things causes uric acid stone. Therefore, it is multifaceted appearance. So this you should not forget. What are the shapes of urinary crystals? What are the shapes of urinary crystals? You must not forget. So shapes of urinary crystals is being asked as image-based question from pathology. So you must not forget this image-based question from pathology. The urinary crystals will be asked in exam. Okay, will be asked in exam. So please don't forget the urinary crystals in exam. Okay, so high yield for your exams. So what are the drugs causing stones? This is the last 2 years. They are repeatedly asking drugs causing renal stones. So the drugs causing renal stones, I used to remember with the mnemonic times call. So times call is a mnemonic. So T for triamprene, the drugs from pharmacology. Triamprene, indinavir. So magnesium trisilicate, this is asked last year. So magnesium trisilicate is available in which one? In antacids. We drink antacid, no? That contains magnesium trisilicate. That will cause renal stone. And ephedrine. So ephedrine can cause renal stone. Septron, the drug simple antibiotic. Septron, ciprofloxacin. These are the 2 antibiotics causing stone. So please remember what are the antibiotics causing stone are? Septron and ciprofloxacin are the antibiotics causing stone. And otherwise acetozolamide. Acetozolamide, loop diuretics can also cause stones. And L is the question again asked in exam, that is laxatives. What laxative means? Magnesium containing laxatives can cause stone. So please remember magnesium containing substances like antacid or laxatives can cause stone. So remember the mnemonic times call. So times call, triamprene, indinavir, magnesium trisilicate, ephedrine, septron, ciprofloxacin, acetozolamide, loop diuretics and laxatives are the drugs which will cause this type of stones. And now coming to the dietary management of stones. Dietary management of stones. How are you going to manage the stones? Many times stones up to 5 millimeter. Management of stones up to 5 millimeter. The stones we don't do anything. They will pass out. Don't worry. Less than 5 millimeter stones. No need of any treatment. No treatment needed. It will come out. No need to worry at all. Okay. So what are the things you should advise the patient? You should advise them increase fluid intake. Ask them to drink more fluid such that you should pass more than 2.5 liters per day urine. Per day you must pass 2.5 liters urine. What are the things he must restrict or avoid? So this is a very practical question because kidney stone patients will come and ask you, sir, what should I eat? What should I not eat? So you must tell them you must avoid taking protein more. Protein should be restricted. So protein should be restricted. You can see many gym patients going for gym. They have protein powders. They have more protein powder consumption. That causes stone for them. Please remember, protein powder consumption by gym people. They consume protein and they get stones. Ask them to restrict salt. Salt, sodium chloride, salt should be restricted. Oxalate should be restricted. Oxalate diet should be restricted. So we also advise them to reduce the non-vegetarian. Non-vegetarian like mutton and all should be reduced. So that contains more of oxalates and they also contain more of uric acid components. So therefore we must advise them to restrict those things. And what we can advise them to take more consumption. This looks like paradox, but see remember, more consumption is advised for calcium supplements. Calcium supplements are more advised. Okay, calcium supplements are more advised for these patients. So though we have calcium oxalate stone, calcium phosphate stone, all those things, calcium supplement will make the calcium deposited in the bone rather than coming in the urine. So calcium supplements are advised for these patients. And this question came in names. What is the juice we can advise them to drink? Most of these renal stone fellows will have this juice in their fridge and they'll be drinking at least 2 to 3 glasses per day. What is the juice? It is not commercially available. It is commercially available only in Tropicana and those boxed juices. It is cranberry juice. So cranberry juice. So cranberry juice has benefit of dissolving the stones. So cranberry juice can be given. And diet that should be restricted or selectively we restrict milk and milk products. Some other products we will restrict, I will tell you later. Just remember, this is the main thing you must do in the beginning. As you see a stone patient, we don't know what is the type of stone, just give them this gross advice. Add them calcium supplement, restrict protein, salt and oxalate diet, and juice should be given to them. And juice should be given to them. What juice we give is cranberry juice is given for them. Okay. So now, coming to the bladder stone. Bladder stone. So what I'm discussing so far is kidney stone. Now what will happen in a bladder stone? Let us discuss what happens in a bladder stone. So please understand, I'm drawing a simple picture to make you understand what is the common bladder stone. This is ureter, this is bladder. Now you see, what is the most common stone in the kidney? I told you what is it? It is calcium oxalate stones. The stone from the kidney can drop down into the bladder. What will happen to it? If it comes to the bladder, what will happen to it? Will it stay there or will it come out? It will not stay in the bladder. It is a very small stone. It has passed through the ureter, so it will come out. It will come out. So this type of stone found in the bladder is known as primary bladder stone. So please remember, primary bladder stone is what? It is a dropped stone from above. The simple one-liner is, it is a dropped stone from above, from the kidney. A dropped stone from the kidney is known as primary bladder stone. Okay, dropped stone from the kidney is primary bladder stone. If the stone is formed in the bladder itself, if the stone is formed in the bladder itself due to some obstruction like bladder outlet obstruction, BPH, bladder neck stenosis, some pathology is causing, or if there is a diverticulum in the bladder forming a stone, some pathology in the bladder causing stone is known as secondary bladder stone. It's known as secondary bladder stone. The stone formed in the bladder itself is known as secondary bladder stone. So this is most common type of stone in the bladder. Please remember, the most common type of stone in the bladder is secondary bladder stone. And what is the type? The type of stone is uric acid stone, which gets coated with ammonium. So the stone what we get in secondary bladder stone is ammonium urate. So it is ammonium urate. So how is it formed? So it is formed by, this is an ammonium urate stone. It gets coated with calcium on the surface. That is known as calcium apoplexy. Calcium apoplexy happens. The predominant component is uric acid. It is also known as ammonium urate stone. It gets coated with calcium apoplexy. Calcium is known as calcium apoplexy. Therefore, they are 100% radiopaque. They are 100% radiopaque stones. Secondary bladder stones are 100% radiopaque stones. Please don't forget it. 100% radiopaque stones because of calcium apoplexy. Okay. So primary bladder stone, the most common type of stone is calcium oxalate stone, but it is not the commonest. It is rare in the bladder. So if they ask you an exam, what is the most common primary bladder stone? Answer is calcium oxalate stone. What is the most common overall stone? It is ammonium urate stone, and it is usually secondary stone, secondary bladder stone. Secondary is a term kept for secondary to some pathology. Secondary to some pathology, there is a stone formed is known as ammonium urate stone. Secondary to some pathology, the stone formed is known as ammonium urate stone. So please don't forget the bladder stones are two types: primary bladder stone, secondary bladder stone. Secondary bladder stone is a stone formed in the bladder itself. Primary bladder stone is a stone dropped from above into the bladder. So primary bladder stone is most common type is calcium oxalate. Secondary bladder stone, the common type is ammonium urate. Ammonium urate. So these are the points you must know in the basics of stones. Before going to the interventional management, these are the basic points you must not forget. Now we are going to see the management of various types of stones. Okay, management of stones we are going to discuss now. In management, the first thing you must know is about ESWL, extracorporeal shockwave lithotripsy. ESWL is extracorporeal shockwave lithotripsy is one type of management. PCNL, percutaneous nephrolithotomy, extracorporeal shockwave lithotripsy. Shockwave lithotripsy. It is a technique in which piezoelectric waves are passed on the stone and broken into pieces. Like a shock wave, the stone it is passed and it is broken into pieces. It is ESWL. Percutaneously, like a laparoscopy, we go inside and remove the stone. That is known as percutaneous nephrolithotomy. Okay, that is one technique. And other technique is RIRS. So retrograde intrarenal surgery. Retrograde intrarenal surgery. So we go through the bladder into the ureter, and through the ureter we enter the kidney and break the stones from the kidney. So in otherwise, let me show you. All these are the three innovative methods or the recent advances in the removal of kidney stones. I am discussing the management of kidney stones. So please remember, up to 5 mm no treatment needed. Up to 5 mm no treatment needed. So ESWL is passing a wave on the stone and breaking it into pieces so that it will come out. That is ESWL. PCNL is by a root, it go inside, go remove the stone and come outside. That is PCNL. RIRS is we go through the bladder, we go into the bladder, from the bladder into the ureter, and through the ureter renal pelvis, we go and bring it through this place itself, through the bladder itself, through the natural orifice, we bring it. That is known as RIRS surgery, retrograde intrarenal surgery. So these are the three newer advances. But old methods, what we used to do when I was doing emergency surgery, we used to do this surgery. Two surgeries we used to do. Number one, we open along the Brodels line. I told you along the Brodels line, we open. We go along the Brodels line, we cut open the kidney like a mango. Cut open the kidney like a mango, go inside and remove the stone. That surgery is known as nephrolithotomy. Nephrolithotomy. Along the Brodels line, we go inside, remove the stone and come out. And another method we open is we open the renal pelvis. We open the renal pelvis, go and remove the stone and come out. That is known as pylolithotomy. So nephrolithotomy and pylolithotomy are the two old techniques. They are open techniques, which can be done by laparoscopy also, but usually old method of open techniques. Open nephrolithotomy, open pylolithotomy are the methods to remove the stones by opening the kidney. Okay, these are all nearly obscure nowadays, not seen at all. With the recent advances in ESWL, PCNL, RIRS, these surgeries are gone. Nephrolithotomy and pylolithotomy are not at all seen in the market. Nobody is doing this. So therefore, these are nowadays outdated surgeries. So therefore, I'm going to discuss one by one about the newer treatments. Let us start with ESWL. High-yield MCQ topic for PG aspirants is ESWL. It is a passing of piezoelectric waves. Piezoelectric waves on the kidney and breaking it into pieces. It is indicated up to what size? Indication up to what size? Indication is up to 1.5 centimeter size. It's very important. Everyone I'm telling is very important. ESW is indicated for up to 1.5 centimeter size. It can be done for which are stones? It can be done. It can be done for kidney stones. It can be done for pelvis stones, renal pelvis. It can be done for upper ureteric stones. It is contraindicated for stones in the lower ureter. Why? Lower ureteric stones, it cannot be done. The reason is very simple. Because there is pelvic bone is hindering the pathway. We cannot pass the piezoelectric waves on it. So lower ureteric stone is a hindrance on the way. So lower ureteric stone it cannot be used. It can be used for kidney, pelvis, upper ureteric stones also. Please remember. Contraindications. Very important question for final years. Contraindications of ESWL are the following. Absolute contraindication. You should never even think about it. Where? In pregnancy and bleeding disorders. Patient who is having a bleeding diathesis and pregnancy, it is absolute contraindication. Pregnancy and bleeding diathesis, it is absolute contraindication. So relative contraindication is, the relative contraindications are if there is an obstruction. In the urinary system, there is an obstruction. For example, there is a distal ureteric stricture or there is a stone obstructing the distal ureter. At that time, we cannot go and break the stone. Okay, distal obstruction. If there is an infection, if you break the stone, the bacteria will enter the blood circulation and cause urosepsis. Okay, and patient having hematuria, patient who is having significant hematuria. So significant hematuria and there is a renal dysfunction. So obstruction, patients, infection, hematuria, renal dysfunction, we cannot use ESWL. So the important complication of ESWL itself is hematuria. Please remember. So after ESWL, the patient will have hematuria. That is why in bleeding diathesis or a patient already having hematuria, if you use ESWL, you will bleed like anything. So please remember, hematuria is an important complication. And another complication is incomplete clearance. Not always the stones break. I told you already, incomplete clearance can happen. Especially MBC stones will not break. What are they? Calcium oxalate, monohydrate, brushite, cystine. These stones are very difficult to break by ESWL. If the stone size is more than 1.5 centimeter and you are breaking with ESWL, one important complication can happen. What is it? If you are breaking a very big stone with ESWL, the stones will come down and will form a street-like thing like this on the ureter. What is this complication known as? This is known as Stein's stress, 100 times asked MCQ. Also known as stone street. The name is stone street or stain stress is usually due to large stones obstructing all along the ureter. So therefore, if you are going to use ESWL for bigger stones, we must always put a stent like this. Always put a double J stent. The stent I will discuss separately with image. So the stent used is like this. It is a self-retaining stent, double J stent, which will be around 20 centimeters. The same stent which we use in bile duct, which is 10 centimeter. Here it is 20 centimeter. Double J stent is inserted. So to prevent this complication of stain stress, we use a double J stent. Remember, we use a double J stent. What is the next method? Next method of surgery is PCNL. Percutaneous nephrolithotomy is indicated for stones very big, like more than 2 centimeter size stones we can use. Very big stones like more than 2 centimeters we can use. We can use in infected urinary system. In infected urinary system we can use. We can use in obstructed urinary system. Obstructed urinary system we can use. You can use in cystine stones. We can use in failed ESWL. Even if there is some anatomical abnormalities, like anatomical anomalies, or if there is a, for example, if there is a calicial diverticulum, if this is callus, the calyx having a diverticulum like this, and the diverticulum is having a stone, this can be used. So calicial diverticulum, calyx, diverticulum containing stones. So what are the indications of PCNL are size more than 2 centimeters, infected stone, obstructed system, cystine stone, failed ESWL, anatomical anomalies. In all these cases, we can go by PCNL. What is PCNL? Please understand. These are the ribs, and let us assume this is a kidney containing a stone. This is a kidney containing a stone like this. So we can put a guide wire or a needle directly into the stone like this or like this. There are two methods which we can approach the kidney. One is transcostal approach. Another is subcostal approach. We form a tract, we dilate the tract, and then we use a special scopy, nephroscopy. I will show you. It is an image-based question. Later I will show you nephroscopy. Nephroscope will be passed inside. Nephroscope will go inside and remove it and come out. So this method, PCNL, percutaneous nephrolithotomy, what are the complications you can expect? So the complications we can expect in general are bleeding, sepsis. We can cause sepsis. We can cause perforation of some bowel, perforation of bowel. I have seen around 3 cases after PCNL we have operated. And by going through transcostal approach, special complications are pleural injury. Pleural injury. Pleural injury can happen. Or you can cause hydrothorax. Hydrothorax. So pleural injury can happen, hydrothorax can happen. Subcostal approach, the problem can happen, or duodenal injury. Colon injury. Very rarely liver or spleen injury. Liver or spleen injury. Or other common injuries are injury to renal vessels. Renal artery, vein, or IVC can be injured while doing this approach. So transcostal is going through pleura, through the ribs. We can injure the pleura and it can cause hydrothorax. Subcostal approach can injure the duodenum or colon or liver and spleen. So nephroscope is used in removal. This is PCNL, most commonly done procedure. It is a minimally invasive procedure. And if there is a huge staghorn stone like this, how will you remove? Staghorn stone like this, we use sandwich procedure. If there is a point sandwich, go with it. Or else go with PCNL. If there is a word sandwich, we can go with sandwich. Or else you have to go with PCNL is the best. So what is sandwich? First we do ESWL and crack the stones like this. Then you go with PCNL. So please remember, first you break with ESWL and then go with PCNL. So staghorn stones, first we do breaking with ESWL followed by PCNL. So that is sandwich technique. But the best technique is, if they ask you single technique which is best, means go with PCNL. Or else you have to go with sandwich, ESWL plus PCNL technique. So please don't forget PCNL. And RARS, retrograde intrarenal surgery, is mainly done for renal pelvis stones. Mainly done for renal pelvis stones and mobile stones, freely mobile stones in the kidney. If it is very much impacted, it is very difficult to remove by RARS. Otherwise, RARS is an upcoming procedure. Retrograde intrarenal surgery, and with retrograde method nowadays, you are having lithotripters which can break the stone and remove. So all these things are not explained in Balian law, so not needed for you. Just remember what I told you so far. And now coming to ureteric stone management. Ureteric stone management. It is very simple. Ureteric stone, you all very well know. What is the gold standard treatment of ureteric stone? Stones up to 5 millimeters will pass out. Don't worry. If the stones are up to 5 millimeters, less than 5 millimeters, no treatment needed. They will come out. If they are more than 5 millimeters or impacted somewhere like this, the treatment is very simple. We put a ureteroscope. Ureteroscopic retrieval using what basket? The basket is known as Darmia basket. Darmia basket. We pass it. I will show you the image of Darmia basket, which will go inside like this, and we open the basket and retrieve the stones out. So this is Darmia basket. And one interesting technique available is known as push bang technique. What is this? This is a 100% expected MCQ from Balian law. Push bang technique. So please guys remember, urology itself is a specialty. It is, when you read, there is a special book known as Campbell for urology, which is more than 2,500 pages, very huge book. So what I am going to focus in this chapter is I am going to focus mostly what is there in Balian law. Balian law itself is extensive. So if you read Balian law for urology, that is enough. No need to read any book. And whatever points there in Balian law, you follow the points. I am also telling those points only. So those I am telling here and there some extra points. Majority of points I have taken only from Balian law. Okay. So please read Balian law for urology for final years. Push bang technique is used for upper ureteric stones. Upper ureteric stones not reachable by normal ureteroscope. With a normal ureteroscope, we are unable to reach the ureter. What we do? If you are unable to reach the ureter by normal ureteroscope, what you do? We push it. For example, see this image here. What I will do? I will push the ureter. I will push the stone into the pelvis. Push the stone back to pelvis. Push back to pelvis. And do what? ESWL. So this is the push bang technique. Push bang technique is done for upper ureteric stones which are unable to be retrieved by ureteroscopy. We push back it into the renal pelvis and remove by ESWL. Okay. After removing any type of stones, we usually put a double J stent like this. So that the ureter will go for spasm, and during the spasm time, the urine will be drained by the stent. So please remember, you have to put a stent. And what is the treatment for bladder stones? I still remember I have operated around 3 to 4 bladder stones by opening the bladder. Like this much stones, we open the bladder, remove the stone and resuture it. That is no more done. What is the latest treatment? The latest treatment is transurethral cystolithotripsy. So now no need to open the bladder at all. You can go through the urethra. Put a scope inside. Cystoscope will be put inside. With that, we break the stone into pieces and retrieve the entire stone. That is known as transurethral cystolithotripsy. So old method of open cystolithotomy is nobody doing. Open cystolithotomy, nobody is doing nowadays. So for cystolithotrypsy, we have multiple machines, lithotripter, laser, multiple options are available to break the stone and remove it. And the commonly used laser by these uro guys are chromium YAG laser and ND YAG laser are the two lasers used by them. So these are the two lasers now urologists are usually using for prostate resection, stone, everything. They are using chromium YAG and ND YAG lasers. And best among the two is chromium YAG laser. Is used by them to break the stones. So please remember now these are the new techniques in the removal of stones. And that is about the stones. Now let me show you the images from this first part. So renal stone part, let me show you the images. So far what we have discussed. So please don't forget this is Bosniak classification, simple cyst. So this is benign cyst. You can see this is complex cyst. Having multiple, see the image, you can see multiple hairline septations. And Bosniak 3 is indeterminate. We are having a confusion, indeterminate. So what I should do? I should do biopsy in 3, category 3, I should do biopsy. In 4 you can see soft tissue components are present. No doubt it is malignant. We must dissect Bosniak 4. So there are 1, 2, 2F, 1, 2, 2F, no need to worry. 3 do biopsy, 4 do dissection for Bosniak classification. I told you MAC 3 is an investigation of choice for uretropelvic junction obstruction. MAC 3 is an investigation of choice for uretropelvic obstruction. What are the sites of stone obstruction? I told you pelviureteric junction obstruction causes pain radiating to where? To the testis. Due to what nerve? Genital branch of genitofemoral nerve. Stone in this lower ureter will cause pain radiating to the medial side of thigh, also known as loin to groin or thigh. What is the nerve carrying this? It is by ilioinguinal nerve. Ilioinguinal nerve carries the pain. So please don't forget the classical symptoms in each place. I have told you, you must not forget. And this is a typical stagon stones. You can see multiple stagon stones. The best method is sandwich method, ESWL plus PCNL. If both sandwich is not there, go with PCNL method. So now observe the images very closely. High yield image based questions from pathology. What is this crystal? You can see I have drawn the same way bipyramidal crystal. Bipyramidal crystalline calcium oxalate. Dumbbell shaped crystalline calcium oxalate monohydrate stones. Dumbbell shaped or hourglass shape. Okay, dumbbell shaped or hourglass. So this is multifaceted appearance in uric acid crystals. You can see hexagonal crystals in cystine stones. Definitely get an image based question. So please remember. So this is coffin lid crystals, coffin lid like. So this is needle shaped crystals in brushite. Coffin lid. So two-white stone patients, triple phosphate stone patients will die and we keep a coffin lid on them. So any calculi 5 mm or less we can wait. They will pass. 5 mm or less we can wait. So details prices, please don't forget it is also known as intermittent hydronephrosis, and we have to advise them cranberry juice reduces stone formation. Please advise them cranberry juice. And what are the drugs I told you? Times call. So what are the antibiotics? Ceftriaxone and ciprofloxacin are the two antibiotics which can cause stones. See, this is one of an interesting patient with a huge kidney stone, bladder stone, such a huge bladder stone. See, you can see this is a conventional old method. We used to open the bladder, remove the stone by as a hole. So this is cystolithotomy. So this is ESWL where the waves are passed directly on the stones under fluoroscopy guidance. The stone is broken to pieces. So please don't forget the complication I told you in ESWL stings class, which is forming all along the ureter. So this is a nephroscope. You can see this is a typical nephroscope. Through this you can see, and through this we have multiple channels to work and remove the stone. PCNL methods. So it is usually indicated for more than 2 cm. ESWL is usually indicated for less than 1.5 cm. Okay, usually indicated for less than 1.5 centimeters. So this is the Darmia basket. You can see the Darmia basket is removing the stones. So you can see this is how the Darmia basket works. See, the Darmia basket is passed through the ureteroscope. Now we are going to open the Darmia basket. It is going to retrieve the ureteric stone and it will remove the stone. Simple method. As you withdraw, the stone will come out. So this is Darmia basketing method. See, after Darmia basketing, we have put a double J stent. We have put a double J stent inside. So double J stent is made inside. Okay, so double J stent will be inserted. This is the method of removing the renal stones. Okay, renal, ureteric, and bladder stones we have discussed. Now we are going to discuss the renal tumors. Renal tumors topic we are going to discuss now. So the first tumor we are going to discuss is Gravit's tumor. Gravit's tumor, also known as RCC, also known as hypernephroma, also known as hypernephroma. So Gravit's tumor, renal cell cancer, hypernephroma, also known as the most common type is clear cell adenocarcinoma, clear cell adenocancer. So I don't know why Bailey has upgraded so many points this edition. 27th edition Bailey has put extensive points on this topic on renal cancer. So anyhow, for PG level I'm taking this topic. So it is most common in men, the ratio of 2:1. The tumor is most common in upper pole of kidney. The renal cell cancer is most common in upper pole of kidney, and it arises from proximal convoluted tubules. Okay, and if you go to the nephrons, it arises from PCT, proximal convoluted tubules. From proximal convoluted tubule it arises, and it is common in the age group of 50 to 60 years. It is common in the age group of 50 to 60 years, and RCC is the most common malignant neoplasm of kidney. Sorry, otherwise there is no other malignant neoplasm except RCC in kidney. Most common malignant neoplasm is RCC. So most common in men, most common in upper pole, most commonly arises from proximal convoluted tubule, most common in the age group of 50 to 60 years, and the most common presentation is hematuria. Hematuria, pain, mass is a triad of RCC. RCC triad. What is RCC triad means? I used to remember HMP, hematuria, mass, pain. Is a mass pain. Hematuria, mass, pain is a triad of RCC. The patient may come to you with a hematuria, pain, or mass. So the point I want you to know in this RCC is they have discussed extensively about the pathology. Extensively they have discussed about the pathology of RCC in Bailey and Lau. So the pathological types of RCC are, the most common type is clear cell adenocarcinoma. So this is the most common type. So what are other types means? The other types are papillary type, papillary renal cell cancer, chromophobe RCC, chromophobe type of RCC, medullary type of RCC. So these are the 4 important types of RCC I want you to know very well in detail. So in this, when you say about RCC, you should know the clear cell RCC is associated with VHL gene mutation. VHL gene mutation, von Hippel-Lindau disease mutation seen at the level of chromosome short p, short arm of chromosome p, that is known as 3p. So 3p mutation causes clear cell adenocarcinoma. So papillary cancer is associated with the trisomies. Certain trisomies like 7, 16, 17. 7, 16, 17 trisomy is associated in papillary cancer and it is associated with chromosome 7 mutation. So clear cell cancer associated with chromosome 3 mutation, VHL gene mutation. Papillary RCC is associated with chromosome 7 mutation. Okay, and interesting question which you can get in exam is sickle cell anemia patients, sickle cell triad patients will get medullary RCC, medullary type RCC is seen in sickle cell RCC patients. So please don't forget the first important point. So clear cell cancer is the most common cancer. It is associated with VHL gene and it is the overall most common type of cancer. And papillary RCC is the one which is associated with chromosome 7. And this is the tumor which is common in most common in polycystic kidney disease patients undergoing dialysis. PCKD patients on dialysis will get this papillary RCC most commonly. So papillary RCC patients, most common in polycystic kidney disease patients on dialysis is papillary RCC. Please don't forget this point. And chromophobe RCC is the one which carries the best prognosis. So these are all some one-liners which I expect may be asked in Bayesian law. So I made these questions. So please remember these questions which can be asked in exams. So I yield MCQ for exams. So clear cell, most common is VHL gene mutation. Papillary, most common is chromosome 7 mutation. Chromophobe type is having the best prognosis. Sickle cell patients will develop medullary cancer. So who will develop papillary RCC means papillary RCC is seen in PCKD patients on dialysis. So in other words, dialysis associated renal failure patients may develop papillary type of cancer. So please don't forget these points. Okay. So coming to the other clinical features, apart from hematuria, mass and pain, HMP, the other clinical features are the following. So please remember, this is kidney. So interesting MCQ, especially for 5 years I'm going to tell now. So this is renal vein. This is renal vein. So the renal cell cancer has a special property to invade and grow into the veins like this. It will grow into the veins and it will grow even into the IVC. It will even grow into the right atrium level. So the important property of renal cell cancer is it can grow into the veins. So please remember, it can grow into the veins, inside renal veins. So as it is growing into the renal veins, is it said to be inoperable? No, it is still operable only. It is still operable. We can open the IVC, we can remove the thrombus also. We can open the IVC and we can remove the thrombus also. It is still operable only. Please remember, it is still operable only. Even if it is in the heart, we can open the atrium and remove the thrombus. It is still operable. So the important point you should know is it is having a special property to invade into the veins. And because it is causing invasion into the veins, the patients may develop interesting clinical feature on the left side testis. Young male patients or any patient, young patient developing sudden varicocele testis on left side. The patients developing varicocele testis on left side is usually due to left side RCC. So left side varicocele, which is irreducible on lying down. Left side varicocele irreducible on lying down is a feature of RCC. So what is the earliest clinical feature and most common feature? It is hematuria. So hematuria is the earliest and most common feature. Please don't forget that. So any patient coming to you with hematuria, you must always be serious and evaluate them. So earliest and the most common feature is hematuria. Irreducible left side varicocele is seen, and other clinical features are it more commonly produces hematogenous mets. Hematogenous mets are very common in RCC. They will produce pulsatile skull secondaries. They can produce pulsatile skull secondaries. They can produce lung mets. The most common distant mets is to lungs. Most commonly to lungs, and the mets are said to be known as cannonball mets. So very common to produce pulsatile skull secondaries like a follicular cancer, and it produces lung mets. Please don't forget these points. And apart from this, non-metastatic some syndromes are seen. They are known as paraneoplastic syndromes. Paraneoplastic syndromes are very common in RCC. So please don't forget, paraneoplastic syndromes are very common in RCC. The features are elevated ESR, increased ESR is the most common feature. Is elevated ESR. Increased ESR is the most common feature seen in RCC. This question has been asked more than 100 times in PGME super specialty exams. So please don't forget the most common feature of RCC, paraneoplastic syndrome, is increased ESR. And when they ask you second common feature, they may ask you second common feature also in exams, that is hypertension. So second common feature is hypertension. Third common feature is what? What is the third common feature? So third common feature is anemia. So I want you to remember 1, 2, 3 alone. So paraneoplastic syndromes seen in RCC are first increased ESR, hypertension, anemia. This is the 3 important features you must not forget. Okay, the 3 important features you must not forget are increased ESR, hypertension, anemia. So please don't forget this 3. Other important features which may be asked in exam are it can produce hypercalcemia. Hypercalcemia is seen in around 5% patients. Polycythemia, what is this? Already anemia is seen, now polycythemia. Yes, both can happen. Polycythemia may be seen in 3% patients. So hypercalcemia in 5%, polycythemia in 3% patients. So what are other features? Other rare features are, one interesting feature which is repeatedly asked in exam is Stafford's syndrome. One question which is repeatedly asked in exam is Stafford's syndrome. What is Stafford's syndrome? Non-metastatic, please remember, interesting point. Non-metastatic liver enzyme elevation. Non-metastatic liver enzyme elevation is known as Stafford's syndrome. So please don't forget, the most common feature is increased ESR, second common feature is hypertension, third common feature is anemia. So ESR, hypertension, anemia. Other features are hypercalcemia, polycythemia, Stafford's syndrome. Others are not so important. Neuropathy, amyloidosis, pyrexia of unknown origin, which is mostly seen in many cases, PUO, pyrexia of unknown origin, or the other features. They may also have weight loss. These are the important paraneoplastic syndromes in RCC. Please don't forget the paraneoplastic syndromes. And in this, I want you to remember non-metastatic liver enzyme elevation. There will be increased LFT without liver mets. It is Stafford's syndrome. Paraneoplastic syndromes in RCC. Coming to the special points, there are some grading system mentioned. So you all know very well there are so many grading systems for many cancers, like Gleason's score for prostatic cancer, like that many grading systems are there. For renal cell cancer, there is a new grading system introduced in Bayesian law known as Fuhrman grading system. So there is a grading system, just to know the names, they have not so far asked this. It is based on the nuclear, it is a nuclear grading system, okay, based on the nucleus. So it is a nuclear grade based on the nucleus abnormalities. We have a grading system known as nuclear grading system of Fuhrman's. And they also have a special scoring system based on the histological features known as Leibovitch scoring system. So I'm expecting one of these two will be asked this year in NEET 2021. So please be focused. So Fuhrman's nuclear grading system and Leibovitch is based on histological features. Histological features we have here. Leibovitz scoring system. Leibovitz scoring is based on histological features. Nuclear grading system is Fuhrman's grading system. Leibovitz score is based on the histological features. So please don't forget Fuhrman grading, Leibovitz score. Very important for your exams. Now let me tell you the staging system given in Bailey and Love. So there are old staging systems known as Robson's staging system for kidney, which is no more. Which is no more there in textbook also, so we not worry about it. Robson staging is the old staging for renal cell cancer. It is no more there. Now we have a classical scoring system based on tumor size. We have in Bailey and Love. I'm discussing that. Stage 1. What is stage 1? Let us assume this is kidney, and this is the Gerota's fascia. This is Gerota's fascia, please understand. And this is perirenal pad of fat. Now let me tell you the staging. So the tumor is more than 7 centimeter. Stage 1. Stage 1. Tumor is greater than 7 centimeter and limited to the kidney only. Sorry, less than 7 centimeter and limited to the kidney. So if it is more than 7 centimeter and limited to kidney, stage 2 is more than 7 centimeter. In both stage 1 and stage 2, you can see the cancer is within the kidney only. So limited to kidney, does not extended anywhere. Okay, does not extended anywhere. So stage 3 is interesting. You see, this is a renal vein I told you. In stage 3, the cancer is infiltrating into the renal vein, the tumor thrombus, infiltrating into renal vein, or it is infiltrating into the adrenal gland. So this is adrenal gland. It is infiltrating into adrenal gland, renal vein, or it is infiltrating into up to the atrium also, or with the regional nodes. Some regional nodes are also involved. Perirenal nodes are also involved. So this is what we say as stage 3. You can see stage 3, it has come out of the kidney but not gone out of the Gerota's fascia. Stage 4 is a condition which has gone out of Gerota's fascia. That is a classical MCQ. So you can get this in exam. So in which stage the tumor has extended out of Gerota's fascia? Answer is stage 4. So this is the staging system we use. Simple staging system. Just with the CT scan we can say. Stage 1, the tumor is less than 7 centimeter. Stage 2, more than 7 centimeter. Stage 3 is the tumor is involving renal veins or the nodes. Stage 4, the tumor has gone out of Gerota's fascia. Stage 4 is one which the tumor has gone out of Gerota's fascia. So now what is the treatment? The treatment is usually we do radical nephrectomy. Whenever we see a case of RCC, we immediately advise them radical nephrectomy if they are operable. So whenever we see a case of RCC, we ask them to remove the kidney. What are the structures removed in RCC? Radical nephrectomy. We remove the kidney. See, please remember, kidney, adrenal gland. So in a radical nephrectomy, what are the structures removed? It's a separate question. So kidney, adrenal gland, 1, kidney, 2, adrenal gland, 3 perirenal pad of fat. Please remember, perirenal pad of fat. 4 is very important. We also remove the nodes, regional nodes. Regional nodes are also removed. And whenever you say radical nephrectomy, it will always contain a part of upper ureter will be included. Part of upper ureter is also included. So radical nephrectomy is a major surgery in which we will remove the contents within the Gerota's fascia. Okay. So content within the Gerota's fascia. Will you remove Gerota's fascia? That is the question I want you to know. Gerota's fascia. Will you remove or not? Gerota's fascia is also removed in radical cases. Also removed in radical nephrectomy. We don't remove Gerota's fascia in partial nephrectomy, which I am going to tell next. So Gerota's fascia is also removed. So radical nephrectomy, Gerota's fascia, kidney, adrenal, lymph nodes, fat, ureter, all these are removed in radical nephrectomy. So, but what are the places where we do partial nephrectomy? What is partial nephrectomy? Otherwise known as partial nephrectomy or nephron sparing procedure. This is other name for this. So, partial nephrectomy or nephron sparing procedure is done only for the following cancers. Number 1, T1, when the tumor size is less than 7 centimeter, we can do. So, this is a NEET 2020 question. The question asked in NEET 2020. The following is an indication of partial nephrectomy is asked in national board exam. Less than 7 centimeters, we can do even in the presence of normal opposite kidney. In case of normal opposite kidney also we can do. In case of T1 less than 7 centimeter. We can little compromise if it is a single functioning kidney. In case of single functioning kidney, only one kidney is functioning and that kidney has got a cancer, we can do nephron sparing surgery. And VHL patients will get bilateral RCC. So for them we will do. And even renal failure patients, we try our best to preserve the kidney, like in diabetes mellitus, hypertension causing renal failure patients also, we will opt for partial nephrectomy. So this question is asked in exam. They asked only the size. So please remember, T1 less than 7 centimeter, we will do nephron sparing operation. T1 less than 7 centimeter, we will do nephron sparing operation. Single functioning kidney we do. VHL patients with bilateral RCC we do. And renal failure, diabetes mellitus and hypertension we do. So these are the points you must know in renal cell cancer. When I discuss about renal cell cancer anywhere, I should also discuss the Wilms tumor simultaneously in pediatric age group. So now let me tell you the differences so that you can understand easily. Renal cell cancer and Wilms tumor you can understand easily by knowing the difference. What mutation I told you in RCC? Chromosome 3p known as VHL gene chromosome. Wilms tumor, the mutation is seen in 8th and 11th chromosome. So what is the age group I told you for this guy RCC? 50 to 60 years is most common. Wilms tumor is common in 1 to 5 years. 1 to 5 years. This is the most common malignant tumor, RCC. Wilms tumor is the most common primary tumor of children. So RCC, what is the presentation I told you? HMP. Hematuria, mass, pain. Same HMP for Wilms tumor triad also. The triad of Wilms tumor also is HMP. Hematuria, mass, and instead of pain, they have pyrexia. Please don't forget, they have pyrexia instead of pain. So mass. Wilms tumor will have mass. Huge mass. The baby will present to you with a huge mass in the abdomen. So along with that, they also have hypertension. The babies also will have hypertension. Weight loss are also seen in these babies. Other features. Okay, please don't forget the Wilms tumor triad. So RCC and Wilms tumor, I'm telling the differences. So other syndromes apart from chromosome 8 and 11, other syndromes associated with Wilms tumor are Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Patients will have Beckwith-Wiedemann syndrome. Weger syndrome. What is Weger? Wilms tumor. So Wilms tumor, aniridia, genitourinary anomalies, and renal anomalies. So this is known as Weger syndrome. Wilms tumor, aniridia, genitourinary abnormalities, renal syndromes. And Beckwith-Wiedemann syndrome will have macroglasia, big tongue, and visceromegaly, and increased insulin production. So these are two rare syndromes seen associated with Wilms tumor. So two rare syndromes associated with Wilms tumor are these two. And coming to the RCC and Wilms tumor, I'm discussing as differences for understanding purposes. So most common distant mets in RCC is where? It is to lungs. Same for Wilms tumor also, it is to lungs. It also spreads to lungs. So preoperative biopsy is not needed for RCC. Pre-op biopsy is not needed to confirm whether it is RCC or not. But Wilms tumor, pre-op biopsy is must. Pre-op biopsy must. In case of Wilms tumor, please don't forget, Wilms tumor, preoperative biopsy must. And RCC, I told you, surgery is done, treatment of choice. Surgery is a treatment of choice. Wilms tumor also, surgery is a treatment of choice. But in RCC, chemotherapy and radiotherapy are less effective, chemo-resistant and radio-resistant. RCC is chemo-resistant and radio-resistant. That is why I didn't discuss anything about chemotherapy or radiotherapy in RCC. But on the other hand, Wilms tumor is chemosensitive and radiosensitive. See, this is one method of preparation. If you see, I'm actually, I can go simply by discussing Wilms tumor. But apart from discussing Wilms tumor, I'm comparing with RCC. When I put a comparison between RCC and Wilms tumor and make a flowchart like thing, you will never forget both topics. This is how you should prepare. Whenever you read one topic, you should make a comparison with a similar topic and compare them and read. When you compare and read, you will never forget. So always make comparative reading. This is very important. So chemosensitive, radiosensitive. The chemotherapy used is vincristine and actinomycin are used. Vincristine and actinomycin are used in Wilms tumor. Sunitinib is a one monoclonal antibody used for RCC, for metastatic RCC. So this drug is used for metastatic RCC. We use sunitinib. So please don't forget this drugs. So vincristine and actinomycin are used for Wilms tumor, and radiotherapy is also effective for Wilms tumor. These are the various points between Wilms tumor and RCC. Now I am going to tell you protocol in the management. There are two protocols in management of Wilms tumor. So protocols in management of Wilms tumor, you must remember this is taken from not from surgery books, it is taken from your OB guide. Protocols in management of Wilms tumor, high yield MCQ for your exams. There are two protocols available for the management of Wilms tumor babies. They are NWTSG, so National Wilms Tumor Study Group, National Wilms Tumor Study Group, NWTSD, National Wilms Tumor Study Group protocol, and another is SIOP protocol, Society of International Society of Oncopediatricians, International Society of Oncopediatricians group, and study group, National Tumor Study Group. So there are two types of people, National Wilms Tumor Study Group and SIOP protocol. So what they do in NWTSG group, as soon as they catch the baby, surgery will be done immediately. Surgery is done first. Followed by what? Followed by chemotherapy. Surgery first, followed by chemotherapy. This is a very important point. But SIOP group, the moment they catch the patient, they put chemotherapy only first. They put chemotherapy first and they shrink the tumor, then they do surgery. So I used to remember the oncopediatric guys are always chemotherapy first, followed by surgery. National Wilms Tumor Study Group guys are first surgery first. So SIOP guys, chemotherapy first. So that is why there is one question recently asked. In which of these two groups you do post-chemotherapy staging? This question is asked in exam. Post-chemotherapy staging. The staging is done only after giving chemotherapy. Post-chemotherapy staging is done for SIOP patients. Society of International Oncopediatricians, they do chemotherapy and then they do the staging. But here in NWSTG, they do the staging before surgery itself. Okay, normally what we do, the moment you see a patient, we stage the patient. Staging will be done, followed by surgery, followed by chemotherapy. But in SIOP patients, the staging is done only after giving chemotherapy. This question is asked in exam. In which group of study they do post-chemotherapy staging, means SIOP will do post-chemotherapy staging. So please don't forget these two protocols. It is especially asked in AIMS, not asked in PGME, it is asked in AIMS. So AIMS, PG question, National Wilms Tumor Study Group will do surgery first. SIOP group will do chemotherapy first, and that is post-chemotherapy staging. Please don't forget, whatever is done, both of them have survival same. Survival is same in both guys. Survival is same in both babies. Okay, and what is the treatment we do is, radical nephroureterectomy. Radical nephroureterectomy is done for these babies. Okay, this is the treatment given for these babies. If there is a bilateral Wilms tumor, please remember, if there is bilateral Wilms tumor, we will first give chemotherapy first. Give them like SIOP protocol. Chemotherapy is given first. Shrink the tumor, and then try to do nephron. After shrinking the tumor, try to do nephron sparing operation in these cases. An interesting point is RCC has a bad prognosis, whereas Wilms tumor have a excellent prognosis. Okay, Wilms tumor have an excellent prognosis. You should not forget. So Wilms tumor important differential diagnosis is what? What is the important differential diagnosis of Wilms tumor? Same age group baby, 1 to 5 years, huge tumor in the abdomen. What is it? It is neuroblastoma, which we will be discussing later in pediatric surgery and neurosurgery chapter. So neuroblastoma is a huge tumor in the abdominal cavity. So it is a differential diagnosis for Wilms tumor. So the differential points now we will read in neurosurgery. Okay. So coming to the next tumor, angiomyolipoma. Angiomyolipoma is actually not a tumor at all. It is a hamartoma of kidney. It is an hamartoma of kidney. It is not a tumor at all actually. It is associated with 50% of patients with tuberous sclerosis disease. The disease is tuberous sclerosis. Those guys in medicine you will be reading, no? Tuberous sclerosis, the features are remembered by the mnemonic epiloia. Epiloia is a mnemonic for tuberous sclerosis. We will have epilepsy, low intelligence, and adenoma sebaceum. So tuberous sclerosis patients will have epilepsy, low intelligence, and adenoma sebaceum is seen in tuberous sclerosis patients. So these patients, 50% will have angiomyolipoma. Angiomyolipoma components are angio, blood vessels are seen, myo, muscles are seen, lipoma, fat is seen. All these three are seen. Angiomyolipoma contains all these three contents: blood vessels, muscles, and fat. Okay, all are present. So investigation of choice for angiomyolipoma is CT scan is the investigation of choice, which will show you the classical fat within the lesion. Fat inside the lesion is catched up. And they have HMB 45 will be positive, expected MCQ. HMB 45 is positive for which tumor? It is positive for malignant melanoma. It is positive for angiomyolipoma also. It is also present in angiomyolipoma. So what are the clinical features the angiomyolipoma patient may come to you is, they come to you with hematuria, hypertension, same like RCC. Hematuria, hypertension, mass, pain, everything the same. Same like RCC they come to you. They may also have anemia, everything will be there. So one interesting point is that angiomyolipoma can rupture retroperitoneally and form a syndrome known as Wunderlich syndrome. Wunderlich syndrome. So this is an expected MCQ. What is Wunderlich syndrome? Wunderlich syndrome is a condition in which there is spontaneous retroperitoneal hemorrhage. In which there is spontaneous retroperitoneal hemorrhage is known as Wunderlich syndrome. Nothing to worry, it is self-limiting. Mostly the bleeding will stop. So it is self-limiting, so no need to get tense about this. It is self-limiting condition. So and what is the treatment of this condition? I told you it is a hamartoma, benign tumor, less than 4 cm, no treatment needed. Less than 4 cm, just send them home. If it is more than 4 cm, we can do partial nephrectomy. So please remember, less than 4 cm, nothing to do. More than 4 cm, we can do partial nephrectomy, or we can go for selective embolization of the branch vessel. Supplying that tumor. That tumor is supplying that we can go for selective embolization if you don't want to do nephrectomy for those cases. So anyhow, nothing to worry. The only problem it can cause is bleeding and nothing will happen. They will stop by itself. That syndrome is Wunderlich syndrome. Okay, are you clear? These are renal cell cancer points. Now I'm coming to the bladder cancer. I'm discussing tumors in kidney, ureter, bladder. Now bladder cancer. So it's a high yield topic. Bladder cancer is a high yield topic because Bailey explains enormously about bladder cancer. So I want to discuss in depth. Bladder cancer I want to discuss in depth. Please remember, renal cell cancer and bladder cancer are two important cancers you have to know in this. So most common type of bladder cancer is what? It is transitional cell cancer. It is transitional cell cancer. The most common cancer is transitional cell cancer. Okay. Second common is squamous cell cancer. Third rare variety is adeno cancer. So third rare variety is adeno cancer. 90% of the patients will develop transitional cell cancer. 10% will develop squamous cell cancer. Less than 2% will develop adeno cancer. Adeno cancer, if at all, is seen from arising from the urachal remnants. The urachal remnants produces adeno cancer. Arises from urachal remnants. Squamous cell cancer is predisposed by what are the components? Squamous cell cancer. It is predisposed by yes. Stones, schistosomiasis, stones and special problems, special disease in bladder, like what? Like a diverticulum in the bladder. So who all will get squamous cell cancer of bladder means yes. What are the yes? Stones, schistosomiasis, special disease in bladder like diverticula. So like long-term catheters, long-term indwelling catheters, all these things can cause squamous cell cancer. So now if you see, I have discussed about the risk factors of adeno cancer as urachal remnants, of transitional of squamous cell cancer as 3 years. What is the risk factor of the most common cancer? TCC, transitional cell cancer of bladder. So the risk factors of transitional cell cancer of bladder, the most common risk factor is smoking. Please don't forget smoking. It's the most common risk factor of transitional cell cancer, and it is also associated with schistosomiasis. So schistosomiasis can cause both transitional cell cancer as well as squamous cell cancer. And very important thing I want you to focus in transitional cell cancer is it is an occupational cancer. So please don't forget it is an occupational cancer. Okay, it is an occupational cancer. What are the occupations? Who will get this cancer? Like petrol bunk workers, dye industry workers, auto drivers, coal factory workers, all those guys will develop this cancer, and mainly due to the following substances. Beta-naphthylamine. Beta-naphthylamine is seen in coal factories. Beta-naphthylamine is seen in coal factories. Diamino biphenyl is seen in aniline dye workers. So beta-naphthylamine, biphenyl is seen in aniline dye workers. And there are many other like amino biphenyl, diamino biphenyl is aniline, amino biphenyl, nitrophenyl. All these are various occupational substances which can cause bladder cancer. So in this I want you to remember aniline dye and beta-naphthylamine dye. These two are important risk factors for causing bladder cancer. So bladder cancer patients, what presentation they come to hospital? The most common presentation is painless terminal hematuria. Please don't forget, painless terminal hematuria is a classical feature of these patients. So at the end of micturition, after completing the urine, the bladder tumor gets rubbed up and bleeds. That bleeding comes as painless terminal hematuria. So many times if this is the bladder wall, this is anterior bladder wall, this is posterior bladder wall. If there is a cancer in the anterior wall, due to constant rubbing, it can also cause cancer in the posterior wall. Due to rubbing of anterior and posterior wall, if from anterior wall the cancer can spread to posterior wall, this is known as kissing cancer. Kissing cancer is a feature of bladder cancer. Please don't forget, it is a feature of bladder cancer. Kissing cancer is a feature of bladder cancer. And the most common site of bladder cancer is near the dome of bladder, dome and lateral wall. So the most common site of bladder cancer in the patients is it is in the dome and lateral wall. Usually we get bladder cancers. So in bladder cancers, now how are you going to investigate? How can you say whether the patient is having bladder cancer or not? So the important old investigation, though not so much useful, still we have to know for MCQ purpose, is examination of urine. Examination of urine for what? Urine examination for special substances which are seen in tumors. They are NMP2 protein and MCM protein. So NMP2 protein and MCM protein are two proteins. NMP2 and MCM2 are the two proteins which are found in urine and they are found to be positive. So this is actually used as a screening test. So for a screening test, we can use these two. NMP2 and MCM are used as a screening test. And investigation of choice to stage the bladder cancer is by means of CECT, abdomen and pelvis. To diagnose this by means of what? No doubt, it is by means of cystoscopy and biopsy. Cystoscopic biopsy is the diagnostic investigation of choice. So please remember, the staging is by CECT, investigation of choice to diagnose is by cystoscopic biopsy. So whenever we discuss about bladder cancer, the most important thing we must know is about the staging. So not important about staging, but only when you know the staging we can manage the cancer. Therefore, I have to give some point about the staging also. See, please remember the staging is very simple. It is not a complicated staging. It is very simple. TA, TIS, T1, T2, T3, T4. I'm not discussing about the node involvement. The most common node involved is obturator node. The sentinel node for both bladder cancer as well as prostate cancer is obturator node. So I'm not going into that. TA is a tumor which is non-invasive papillary cancer. Non-invasive papillary cancer is known as TA. Non-invasive papillary cancer is known as TA. TIS is carcinoma in situ. Carcinoma in situ. So T1 is a tumor involving subepithelial connective tissue. Subepithelial connective tissue is T1. It survives involvement of the mucosa, which is nothing but subepithelial connective tissue. Now starts the tissues. T1 is subepithelial connective tissue. T2 is muscularis propria involved. Muscularis propria of the bladder is involved. Perivesical tissues involved. T3, perivesical tissues involved. So T4 involves adjacent organs. What are the adjacent organs to bladder? Prostate, yes, very good, prostate. Seminal vesicles. In males, prostate and seminal vesicles. In females, even vagina or even abdominal wall. So this is a simple staging, you can see. Because why I'm telling the staging is very important, because I'm going to tell the treatment, prognosis, everything based on this staging only. So I want you to know about this staging. I yield for your exams. So please don't forget, TA is non-invasive papillary cancer, TIS is carcinoma in situ, T1 is subepithelial connective tissue, T2 muscularis propria, T3 perivesical tissue, T4 is adjacent organs. Now I'm going to divide the total CA bladder into 3 headings. What are the 3 headings for cancer bladder now? So nothing to mug up. If you understand, simply remember the T staging. Did I tell T staging in many cancers? I didn't discuss in depth in many cancers, but here I'm discussing because I want to tell the treatment based on this. So non-muscle invasive cancers. Can you tell me what are all non-muscle invasive? I'm classifying the bladder cancer into 3 categories now. Non-invasive muscle cancers are nothing but TA and T1. That's all. Superficial cancer, non-invasive, superficial papillary cancer, and T1 involvement of subepithelial connective tissue is T1. And then comes muscle invasive cancers, which has invaded the perimuscularis propria, muscle invasive. So it is T2, which has gone beyond T3 and which has gone up to adjacent organ is T4. And see, now I'm discussing in situ also. In situ tumors, not like other cancers, they carry poor prognosis. Unlike other cancers where carcinoma in situ have good prognosis, bladder cancer has poor prognosis, less than 5% survival. So non-muscle invasive cancers have the excellent prognosis and they have 75% prognosis. So muscle invasive cancer has 25% prognosis and it is also having worst prognosis. So now you can see, I just made it the entire T staging into 3 headings. So I made it very simple. Non-muscle invasive, superficial, TA and T1. Muscle invasive, T2, T3, T4. In situ cancers which are having poor prognosis. So I have made it into 3. Simply I have made the cancers into 3 now. So what I'm going to do now for each cancer, it's going to be based on this. So non-muscle invasive cancers, the treatment we give is TURBT. What is this? Is the initial treatment of choice. Initial treatment of choice is transurethral resection of bladder tumor. Transurethral resection of bladder tumor is a treatment of choice for non-invasive cases. And after TURBT, we can give BCG vaccine inside the bladder. Intravesical BCG vaccine is also put inside after transurethral resection of bladder tumor. So what is the treatment is, we have initial treatment of non-invasive is, non-muscle invasive, put a cystoscope, go inside, cut the tumor, remove it out. After removing the tumor, to remove any small residual tumors, we put a BCG vaccine. So, but the problem is, many cases will recur. Increased recurrence rate is seen. For the following tumors. High-grade tumors, T1 tumors, simultaneous in situ cancers. Please remember, simultaneous in situ cancer was present there. That is one another reason. And if there is multiple tumors. So what are the causes of increased recurrence after T or BT? Or if there is a high-grade tumor, if it is a T1 stage involvement of mucosa. So TA has good prognosis, T1 little less prognosis. Simultaneous in situ cancers and multiple tumors are the reason for recurrence rate. Coming to muscle invasive cancer, the options are radical cystectomy. So whenever possible, radical cystectomy is a treatment for muscle invasive cancers followed by chemotherapy. Or we can give neoadjuvant chemotherapy followed by radical cystectomy. So anyhow, we will do radical cystectomy. So we can do either radical cystectomy followed by chemotherapy or neoadjuvant chemotherapy followed by radical cystectomy. Both can be done. Okay. For a muscle invasive cancer, I will discuss in detail later. So for a carcinoma in situ cancers, there is high risk of muscle invasion. So high risk of muscle invasion present. High risk of muscle invasion is present in situ cancers. Therefore, initial treatment will be what? BCG is the initial treatment of these patients. If it is not responding, then we go for even cystectomy is done for these patients. So that is in situ cancers have high risk of muscle invasion. Initial treatment will be BCG. If not responding, we will go for cystectomy also. So what is this in situ treatment? Let me first explain about it. So what is this intravesical therapy? Intravesical therapy is not advised for muscle invasive cancers. It is advised only for in situ cancers. It is advised for in situ cancers and for non-muscle invasive cancers. The therapy used are mitomycin C, doxorubicin, thiotepa, and BCG. Among this, BCG is best and most effective. So what we do is we put a small Foley's catheter inside, we push this therapy inside the bladder, and we leave these agents inside the bladder for 2 hours, and then we let out the content. So like that is an intravesical therapy that can be repeated again also. So intravesical therapy with the mitomycin C, doxorubicin, thiotepa, BCG is best. So this is mainly done for in situ cancers. Now at this point of time, I want you to know, in this topic, I want you to know about radical cystectomy and reconstruction procedures. So radical cystectomy and reconstruction you must know in details. So in a radical cystectomy operation, what are the structures removed? I told you, radical nephrectomy, what are the structures removed? Here you must remember similarly, bladder with surrounding fat. Bladder with surrounding fat should be removed. Then what else will you remove? We must remove prostate and seminal vesicles. Prostate plus seminal vesicles in male, and uterus plus cervix plus fallopian tube plus anterior vagina, anterior wall of vagina will be removed in females. So prostate and seminal vesicles in males, uterus, cervix, fallopian tube and anterior vaginal wall in females, and plus or minus we also remove the urethra. If the urethra is also involved or very nearby, we may or may not remove the urethra also. And also we will remove the pelvic lymphadenectomy, it should be done. We will also do pelvic lymphadenectomy. After doing all these things, we have to implant the ureter into some conduit. That is the main discussion in this chapter. So radical cystectomy is completed. Now the 2 ureters are remaining out. Where to continue it and where to drain the urine. That is known as conduit, urinary conduit. So urinary conduit is a high yield topic for PGME exams. Now let me discuss about urinary conduit. Definite question for your exam, so please be focused. Urinary conduit. So urinary conduit, I want you to remember what happens. So this is the kidney, this is the right ureter, this is a kidney, this is a left ureter. Now you can see the right ureter, left ureter are hanging like this. This is a bladder and this is prostate and this is urethra. Now what I have done in a radical cystectomy for a bladder cancer here, I have removed everything here. Now the two ureters are hanging. So the commonly used conduit is I will take a loop of jejunum with a well vascularized loop of ileum. Ileum will be taken with its blood supply, the mesentery will be preserved. I will close one side and other side will kept as ileostomy. This is what we commonly done. 95% of the surgeons do this only. So please remember, 95% of the surgeons will implant the ureter into the ileal conduit. They will close one side and they keep one side as ileostomy so that the urine will come out through this ileostomy. So this is most commonly used conduit. The most commonly used conduit, and the most common complication is what? The most common complication in this conduit is stricture at the ureter's orifice. This ureteric orifice can develop stricture, ureteroileal stricture. So please remember, the most common complication is ureteroileal stricture. So this question can be asked in an exam because this point I am telling you is taken from none other than Valiant law. So the most commonly used conduit is ileal conduit and the most common complication is ureteroileal stricture. Okay, please don't forget this first point. Second point, what I can do, another one procedure is I can drain both ureter, olden days method, both ureter can be drained into the sigmoid colon, will be drained into a sigmoid colon. The urine can be drained into the sigmoid colon. This is known as colon conduit. What is the main advantage in this? What is the main advantage of this colon conduit? Can you just think about it and tell me what is the main advantage? So no need of any stoma. There is no need of any stoma. Patient can pass urine through the anus. So the urine will come out through the anus. Urine will come out through the anus. That is the main advantage. There is no separate conduit needed. Therefore, to do this procedure, we must infuse 200 ml saline inside the sigmoid colon, and we should see whether the patient is having normal anal continence. Normal anal continence is very important, should be there. 200 ml of normal saline is infused, and we look for normal anal continency. So if normal anal continence, the patient can grip his anal sphincter with 200 ml saline, then only we can do this procedure. Otherwise, we cannot do this procedure. Colon conduit. The most common problem in this is infection, which can go from feces into the ureter. From here, the infection can go into the ureter, and there is a risk of malignancy seen. So risk of malignancy is also present. Please don't forget this. So most common problem is infection, and there is a risk of malignancy present. So this is problem with colonic conduit. With a colonic conduit. So is there any other option? Yes, there is one more option. If you see, these are the two ureters hanging like this, and the patient had bladder tumor not involving the membranous urethra. So what we can do? The membranous urethra is not involved. So what we can do? We can leave a cup of bladder here. A cup of bladder is left here. Now we bring a segment of ileum like this, and we create a new bladder. We can create a new bladder. We can create a new bladder can be created. So the ureter can be put into this like this. So this is a new bladder creation using ileum. Using ileum, we can create a new bladder like this. So this is one another procedure. If membranous urethra is not infiltrating. Another method is continent urinary diversion. So in otherwise, so I'm making a stoma here. The urine has to come out here continuously. We can make it as a continent by like a Cox pouch. Cox ileostomy. I hope you remember when we discussed ileostomy. It is a continent ileostomy. The ileal tip will be made like a wall. This can be done. Or we can put an appendix. Appendix can be used with its wall so that the urine will not come out by itself. That procedure, appendix used as a urinary conduit, is known as Mitranov procedure. This question is an expected MCQ. Mitranov procedure is appendix used as a urinary conduit. Please don't forget this procedure. Appendix used as a procedure. I will show you that image, you understand. So these are continent type of ileostomy, continent type of urinary diversion. So what is the major problem with these type of conduits? Conduits, the major problem is what? So the conduits we use are ileum. We can use ileum. Other people also use jejunum. Some people use colon, as I told you, colon. Some people also will use stomach. See, very rarely some people also use stomach. All these conduits have major electrolyte imbalance. Major electrolyte imbalance. I want you to remember for ileum. Definitely you should remember for ileum because that is what we commonly do. What problem can happen in ileal conduit? Can you tell me? They will develop metabolic acidosis. Because of various electron exchange, they will develop metabolic acidosis and what? Plus increased chloride level, hyperchloremia. They will develop metabolic acidosis and hyperchloremia. In otherwise, acid increases, chloride increases in their body, HCl increases in their body. Because of ileal conduit being made, they get more of H plus and Cl plus. So Cl minus. So hyperchloremia and metabolic acidosis is seen with ileum. So just remember this point. Same problem is also seen with colon. Metabolic acidosis plus increased chloride is also seen in colon. So therefore, if there is a metabolic acidosis, we cannot use this type of conduit for patients who are having renal failure. So therefore, in renal failure patients, we can use ureter can be implanted into the stomach in renal failure patients. If there is a renal failure, the ureter can be implanted into the stomach. So that will cause metabolic alkalosis. Metabolic alkalosis with increased chloride is seen in these patients. So if you use stomach, the changes you will develop metabolic alkalosis. So therefore, it is used only in renal failure. Only for theory it is there in Valiant law and otherwise it is not so important. Nobody does in stomach practically. So what is seen? Everyone will develop metabolic acidosis. See, please remember, ileum conduit metabolic acidosis. Jejunal conduit also metabolic acidosis. Colon conduit also metabolic acidosis. Only one fellow who develops metabolic alkalosis is stomach conduit. All cases will develop hyperchloremia, increased chloride. Only jejunum will develop hypochloremia. So these are all vulnerable MCQs. Hypochloremia is seen only with jejunum. So jejunum will develop hypochloremia. So therefore, how to manage these patients with conduit? Management of these patients with conduit is they are having increased H plus, they are having increased chloride in their body. Metabolic acidosis and hyperchloremia. Therefore, what should I do? I should give them IV saline with soda bicarbonate. So IV saline mixed with soda by small doses of soda bicarbonate can manage them. Or else we can give them oral potassium citrate. Oral potassiam citrate with sodium bicarbonate should be given TDS per day. So how to manage this metabolic acidosis complication means we give them a syrup of potassium citrate and sodium bicarbonate to drink 3 times per day. We ask them to drink 3 times per day. Okay. And after completing all these surgeries, the chemotherapy is given for them. Adjuvant chemotherapy is beneficial for bladder cancers. And now the latest chemotherapy is GC regimen. GC regimen is a red test regimen we are using now and it is found to be beneficial. It is gemcitabine and cisplatin regimen. Gemcitabine plus cisplatin regimen is what we are now using, GC regimen. And old regimen is MVAC. Most of you will be knowing MVAC regimen is old MCQ. MVAC regimen is used for which cancer is bladder cancer. It is mainly methotrexate, vinblastine, actinomycin and cisplatin. So this is the old regimen we are using, cisplatin regimen, which is mainly used for lymph node positive cases and locally advanced cases we give MVAC regimen. Okay, so please remember the MVAC regimen can be given and chemotherapy can be given either as adjuvant, also as neoadjuvant also we can give chemotherapy, and post-op RT is not much beneficial. Post-op radiotherapy is not beneficial. So these are the points I want you to remember from this cancer on bladder. Let me now show you the images about these cancers which we discussed now. The cancers which we discussed are tumors in kidney and bladder is the topic we are discussing now. So renal cell cancer is also known as Gravid's tumor and it is most commonly associated with what mutation? VHL gene chromosome 3. Papillary cancer associated with trisomy 7 and chromosome 7 mutation. Medullary cancer is associated with sickle cell trait. So please don't forget these points. And what is the MCQ from papillary RCC? Who will get papillary RCC? Dialysis associated polycystic kidney disease patients. Most common type seen in dialysis associated polycystic disease is papillary cancer. In sickle cell anemia, the cancer is medullary cancer. Please don't forget these points. So this is a typical RCC in the upper bowl of kidney. So the classical triad is hematuria, flank pain, flank mass. And these are the typical cannonball mets you see in lungs. Cannonball mets in lungs. So what are the scoring systems I told you? What is Stauffer syndrome? Non-metastatic liver enzyme elevation is Stauffer syndrome. Most common paraneoplastic syndrome is increased TSR. So what are the grading system I told you? Furman's grading system and Leibovitz scoring system. Don't forget these two names are from Bailey and Love. So Leibovitz is based on histological features. Furman grading defines a nuclear grading. It's based on the nucleus. So on the stage of cancer, less than 7 cm in greatest dimension, more than 7 cm and involving veins but limited with gerotasphasia. Stage 4 is beyond gerotasphasia. Stage 4 is beyond gerotasphasia. Please don't forget the indications of partial nephrectomy is less than 7 cm and structures removed in radical nephrectomy. Wills tumor is also known as nephroblastoma. Common age of 1 to 5 years with chromosome mutation 8 and 11. Okay, so Wills tumor triad, mass, pyrexia, hematuria. So it is both chemosensitive and radiosensitive. You can see such a huge tumor. Most common presentation of Wills tumor is mother noting a lump in the baby's abdomen on giving birth. On bathing the baby, the mother notices a huge lump and brings the baby to hospital. That is the most common presentation of Wills tumor. The mother brings the baby with a huge lump. So Weger syndrome and Beckwith-Wiedemann syndrome are the two syndromes, and don't forget NWTSG group and SIOP protocol. SIOP protocol is post chemotherapy based staging. Asked in exam. Post chemotherapy based staging is SIOP protocol. Angiomyolipoma is a benign tumor which is actually a hamartoma. And this is angiomyolipoma. You can see the fat component inside the center, and you can see CT scan is investigation of choice. You can see a retroperitoneal hemorrhage, spontaneous retroperitoneal hemorrhage. It is self-limiting, no need to worry. So bladder cancer, I told you all the points. So what is the urine components you should see? NMP2 and MCM proteins you must see in the urine. So this is the bladder staging. Only based on the staging I can discuss the management. That is why I was discussing there are three types of cancers: non-muscle invasive cancers, muscle invasive cancers, and carcinoma in situ. Non-muscle invasive cancer treatment of choice is transurethral resection of tumor. Okay, muscle invasive cancer treatment of choice is radical cystectomy. In situ cancers, the treatment of choice is BCG. Initial treatment is with BCG. So you can see this is intravesical BCG therapy being given inside. Okay. So please don't forget this is a conduit shown here, which is a pakka ileal conduit. So whatever you are reading or forgetting, don't worry. Please don't forget ileal conduit. You can see this is ileal conduit. We can make it as a continent conduit by a Cox pouch or a Metcalfe procedure. They will have metabolic acidosis and hyperchloremia. They will have metabolic acidosis and hyperchloremia. Who will have metabolic alkalosis? Only gastric conduit. Okay. So please don't forget these points. Colonic conduit will have high risk of infection from feces. Okay. So appendix buried and used as a conduit tip is Metcalfe procedure, and this is a picture showing you Metcalfe. You can see the appendix can be cut and it can be used as a urinary conduit. So whenever you use appendix as a urinary conduit, it is known as Metcalfe procedure. So what are the various conduits and what are the points I told you? Please remember these points. High yield for your exams, conduit electrolyte abnormalities, and what is the fluid of choice for hyperchloremic metabolic acidosis? If you give IV, we give soda bicarb IV. If you give oral, you give potassium citrate with soda bicarbonate 3 times per day. You must give the patient to take this 3 times per day. That is about the tumors in the urinary system. Okay, tumors in the urinary system. Next we are going to see infections in urinary tract. Okay, infections in urinary tract we are going to discuss now.